Hello everyone, I am Kumar, faculty in Physiotherapy from NIEPMD, National Institute for Empowerment of Persons with Multiple Disabilities. It's located in ECR, Chennai. I have in this video about a part of a pulmonary rehabilitation series of videos. So this will be dealing with a prevailing situation where COVID-19 affected patients and then the survivors who are still with the persistent or residual symptoms. Most of the symptoms is difficulty in coughing out the secretions of the lung, and then we will be having a difficulty in breathing. So here we are going to have a learn about a technique that is going to increase the amount of secretions spitting out by the patient, and then without any tiredness or without any pain around the, because the continuous coughing during this period, what happens is most of the patient complain of chest pain, pain around this area, pain around the chest area, and tenderness. When they touch, they will feel the pain around that area. They will be having a difficult to spit out the sputum because of the tired or fatigued muscles, tired muscles in around this area. So thinking about the pain itself, will be reduce the intention of voluntarily spitting out the sputum to cough. So this technique will have
46 வந்திருக்காங்க சார். அப்படியே பேசலாம் சார். கார்த்திக் பாபு சார் வந்துட்டாரு, டைரக்டர் சார். டைரக்டர் வந்துட்டாரு சார், ராஜேஷ் சார். ஸ்டார்ட் பண்ணிட்டு சரி சரி சரி.
Dr. Santosh, am I audible?
Yes, sir. Yes, sir. Audible, sir.
Yes, sir.
Okay, fine. Now, am I visible?
Yes, sir.
Yes, sir. Visible, sir.
Okay, nice.
So, shall we start, sir?
Yes, we can start.
Yeah. Esteemed guests, students, and participants, we warmly welcome you to the NIEPMD World Stroke Day 2023 webinar on recent advances in stroke rehabilitation. As we commemorate World Stroke Day, let us remember the importance of stroke prevention, treatment, and rehabilitation. Together, we can make a difference in the lives of those affected by stroke. The World Stroke Day, observed annually on October 29th, serves as the global platform to raise awareness about stroke prevention, treatment, and support for stroke survivors. This day highlights the importance of early recognition of stroke symptoms and encourages individuals to take proactive steps in reducing the stroke risk. By fostering the education and advocacy, World Stroke Day aims to reduce the burden of stroke worldwide and improve the quality of life for those affected by this medical condition. Here we are now honored to have with us today Dr. Nachiketa Ravas, Director Sir of NIEPMD. Through his continuous support and guidance, you have been invaluable making this event a reality. Sir, I request you to give an inaugural address on this event. Sir.
On this day, the World Stroke Day, which is being celebrated, I congratulate the Department of...
Sir, voice is little low, sir.
Voice is a little low.
Yes, sir.
Just a moment. Is it okay now?
Yes, sir. Yes, sir.
Better.
Yes,
Okay.
sir.
On
Yes, sir.
on this day, I congratulate the Department of Speech, Hearing and Communication and the Department of Therapeutics for coming together to conduct this program. A much essential program. The reason is because of the change in lifestyle, because of the continuous stress, which is either environmental in nature or which is because we are much more isolated into the we to I part. There are incidences of strokes which are happening in much younger population as well. It is the need of the time to bring about awareness regarding the condition, how to prevent it, and in case it happens, how to handle it. I was in conversation with an eminent speech language pathologist whom we would be hearing now,
Somebody do that.
Dr. S.P. Goswami, who was kind enough to say yes to this program as well. He said that earlier we used to hear that stroke is a phenomenon which was there in people who are above 60. But now we see it's happening more and more in the younger age population. The first 1.5 hours in which stroke has happened are much more crucial, because in this particular period of time, if the person is taken to the nearest hospital, which has all the facilities, then the chances of recovery are high. Similarly, after discharge, there is a critical period in which the spontaneous recovery happens. If we can capitalize that the maximum, then the person having stroke would be stepping back to normalcy. To elaborate upon such topics, we need to have a multidisciplinary team, because stroke doesn't affect just paralysis to one part or paresis to one part. It affects the language areas as well, because of which communication and aphasia of various types happen. One of the rarest type of a CRE which we are having, in which we have one of the most eminent speaker on the topic neurotherapeutics in stroke rehabilitation, Dr. Karthik Babu S, who is a PhD as well as the principal for College of Physiotherapy, KMCH. And we have Dr. S.P. Goswami, who is a very well-known person in the area of adult language disorder. He focuses his work on aphasia, and we'll be hearing him as well as the next speaker. I welcome both of you, sir, and I thank both of you to spare your time and join us on this day. Last thing, the moment we start thinking we are alone, the entire set of stress is ours, everything starts complicating. The moment we start thinking we are a part of the larger set of the society, then the stress part also comes down, because there is somebody to take care of you. The responsibility is shared, and multiple types of things. I'm happy to inform that today on 31st of October, we celebrate the Rashtriya Ekta Divas, or the Unity Day, because Sardar Vallabhbhai Patel was born on this day, and he is given the credit to unite all of us. Otherwise, we would be split into various small states within India. On this day, We are celebrating the day by the Unity Day run, as well as by taking the pledge. So there will be a pledge which will be posted as well, and all of you can read the pledge as and when you find time, so as to remind ourselves that we belong to a country which is united, although it's a very diverse country. So with these words regarding the importance of both the disciplines, physiotherapy and speech language therapy, joining hands, and the fact that today is National Unity Day, I would like to formally inaugurate the program and wish all the best to both the departments. And I hope all the 85 participants who have joined on this day would enjoy learning from the varied field of physiotherapy and speech language therapy. Thank you, one and all. Namaskar.
Thank you, sir, for your wishes and your continuous support. Once again, I'll thank you for this for the event to be happening. Thank you so much, sir. Now, I like to call up our head of the department, Dr. Santosh Khanna, Department of Therapeutics, Physiotherapy Division, to have a few words to start over the event.
A very good morning to one and all present here. Thanks to our director who has given us an opportunity to go with this webinar. Thanks to our eminent speaker, Dr. Karthik Babu S, who has graciously accepted to be part of this program. I know that he was traveling abroad and yesterday he just landed and immediately he accepted to take up this program. Thank you so much, sir. And I also thank Professor Goswami, who is Academic Council Chairperson of NIEPMD, who has also graciously accepted to be part of this webinar. So we all know stroke is a very important area that actually needs to have so much of awareness to be created across. Why? Because every year around 12 million people are affected by stroke. This is the data that I just want to put out some data so that we could say why the stroke, we need to talk about this awareness of a stroke and why World Stroke Day is so important. One is around 12 million people every year is affected by stroke. Around 101 million people are living in this globe with after effects of stroke. Around 143 million life years, healthy life years are affected because of stroke. Around 1 in 4 people uh, who are healthy people are having a probability that they can get affected because of stroke. 60% of people at the age of around less than 70 years having probability of getting affected by stroke. Around 16% of people at the age of around 50 years are having probability to get affected by stroke. So these are some alarming data that actually gives an insight why stroke rehabilitation is so important. Around half the people, around 50% of the people who are getting affected by stroke sees their last days immediately, they die. And the remaining 50% have a devastating effect on their physical ailments. Maybe it may be physical, it may be speech, it may be emotional, it may be feeding, so on and so forth. So with this, so much of sufferings they have to live across. So, and this actually brings so much of burden, financial burden, social and emotional burdens on individuals, their family, the community, and even to the government. Because government has to provide some programs either on the health or the social sector where we are much connected into. And stroke is actually is evolving in low and middle income countries and very fast pace. And this impact of stroke, what it has been, data says that it will be costing around more than $1 trillion. The rehabilitation and the treatment component for stroke will be costing more than $1 trillion by 2030. This is what the data actually says. So we have an immense role as rehab professionals, as allied health professionals, that we need to talk more on this, on preventive aspects. If we are able to do, that's the maximum. Then the treatment aspect, and finally the rehabilitative aspect. For all those things, we actually require a good team of professionals who will be able to create awareness among professionals, caregivers, patients, so that this component, this information can spread across, so that as director said, we have this golden hour, what could be done so that the people could be prevented or at least remediated at the earliest. And this has a very unique component because it also affects the GDP. It says because of stroke, the world GDP gets affected by 0.66%. So 0.66% of global GDP is around $1 trillion. That much is the financial costing for the entire globe because of stroke. So this is a bigger area, a larger area of interest where we need to create so much of awareness. In this program, we have two eminent speakers. I am so happy to collaborate with Dr. Karthik Babu again because he has very good publications and research eminence on stroke. So very happy to be part of you, sir, and I thank you so much for collaborating with us, graciously accepting to be as our resource person. A few of his credentials: he is the principal for KMCH College of Physiotherapy. He has 61 papers published for his credits. He is the investigator in one of the research in biotechnology research council. It's called BIRAC, and he also holds an H index of around 12 for his research credentials. And he is also the member of highly accredited journals in the editorial board. So I welcome you, sir, to be part of this program. I also welcome Dr. Goswami, who is our esteemed chairperson for our academic council, a proud recipient of CV Raman Fellowship, professor in speech and speech language pathology in AISH, Ministry of Health, Govt. of India. So with these two eminent speakers, I believe that we'll be able to enlighten the audience with so much of information and knowledge about stroke. So you can be proud to take home some valuable informations which you can spread across. And the ultimate goal of this program is to create awareness and to try and prevent as much as possible and reduce the global burden which is happening because of stroke. Thank you all, and thanks for the opportunity.
Thank you, sir, for giving a valuable facts and important aspects of the rehabilitation that has to be concerned in a stroke rehabilitation as a physiotherapist should be concerned about. And thank you for your support and then continuous guidance in organizing this webinar. So now moving on to the webinars, we have two sessions. First session is by Dr. Karthik Babu sir is on NeuroTherapeutics in stroke rehabilitation. And second session will be by Dr. Goswami sir of stroke and on the topic of stroke and aphasia. So now I invite our resource person, Dr. Karthik Babu sir, for today's speak on the topic NeuroTherapeutics in stroke rehabilitation. Dr. Karthik Babu S, PT, PhD is a multi-talented professional who excels as administrator, researcher, educator, and clinician. He earned a master's in neuroscience and PhD in trunk rehabilitation post-stroke from Manipal Academy of Higher Education, India. Currently, he serves as a principal and professor at KMCH College of Physiotherapy, Coimbatore. Dr. Karthik is also a co-principal investigator for Biotechnology Industry Research Assistant Council funded project. He is highly regarded for his extensive research contributions with 61 papers published in recognized journals and numerous applauds, including Best Lecturer and Scientist Award. He holds an H index of 12 and is associated with esteemed editorial boards like Frontiers in Human Neuroscience and the World Journal of Pediatrics. Dr. Karthik actively participates in International Mobility Task Force and has received international certification in various therapeutic modalities. We are privileged to have Dr. Karthik sir with us today and eagerly waiting his insights and expertise on the topic. I'll welcome you to the webinar, sir. Please, over to you, sir.
So, good morning, everyone. Sir, am I audible?
Yes, sir. Yes, sir.
Sir, respected Dr. Executive Rao, sir, Director of National Institute, NIEPMD. Respected Dr. Santosh Khanna, HOD of Department of Therapeutics. My colleague, Dr. Goswami, speech language pathologist, and the organizing team, dear faculty and students. Warm greetings to everyone. Firstly, I'm delighted to be part of this event. Congratulate the organizing team for arranging such wonderful webinar. And also, I extend my heartfelt appreciation for inviting me to deliver a lecture on this particular occasion. So, shall I start my lecture, sir? Am I audible?
Yes, sir.
The voice is
Sir.
clear? Right. Okay, I'll share my screen.
Yes, sir, please. How much? 2000 finish marks, sir. 96 marks, sir.
Classmates.
So my PowerPoint is visible now?
Yes, sir, it's visible, sir. But it's not the mode. Sir, it's not in the presentation mode, actually.
Oh, no. How, sir? Is it visible?
Yes, sir, it's visible. Thank you.
Right. Yeah, once again, very good morning. So let me start my presentation. I'll limit my presentation up to 45 minutes time. And probably we may have some discussion, maybe last 10 minutes or 15 minutes. So I'll keep my talk very simple. Suppose if my pace is too fast, you can stop me. So NeuroTherapeutics and stroke rehabilitation. Basically, so we have conventional approaches. It's called neurophysiological approaches. In other ways, it's called traditional neurophysiological approaches. And then we have a lot of recent developments in stroke rehabilitation. Traditional neurophysiological approaches are the one that is used worldwide by physical therapists, although they do not have a sufficient evidence-based literature. But definitely these approaches are useful in treating patients with an acute stroke or subacute stroke if they are used within the frame of their principles. So traditional neurophysiological approaches are such as Roots approach, root trunk movement therapy, neurodevelopmental therapy, proprioceptive neuromuscular facilitation, and the motor relearning program. These are the approaches we are familiar with. I'll throw light on the basic principles on how to approach these philosophies. As a physical therapist, we actually involve in motor control and motor learning. So motor control is nothing but understanding the posture and movement. So any patients with a neurological disability suffer from motor control. So they lack the postural control and movement control. And motor learning is something about how we acquire those posture and movement skills. In a simple term, motor control begins with a mobility. So we need to have a range of movement. Within the available range of movement, one should have a muscular control. And then one should have a controlled mobility. In other words, it is called mobility over stability. If that mobility over stability is well executed, then one would say that someone has very good skill. People with neuromotor dysfunction, particularly stroke, would lack this particular control. And these approaches, as I said, the traditional neurophysiological approaches, the philosophy is basically from the existing knowledge about the motor control theories of those days. When these approaches were founded, conceptualized by the members, so they conceptualize this approach based on the control theories available of those days. The commonly used approaches such as Roots approach, root trunk movement therapy, NDT, are based on reflex hierarchical model, reflex hierarchical theory. The MRP is based on systems model. I'm not going much in deep about these theories. Probably we know reflex hierarchical theory is something about the lower centers are controlled by the higher center. Kind of the brainstem controls the spinal cord, and again brainstem is controlled by the cortical center, right? So even there is an injury to the cortex or the subcortical structure, and what happens is that the brainstem and spinal centers release its signal, so they're not under control. So this is the frame of reflex hierarchical model. System model is something about we have to consider other systems as well besides neuromuscular control. We need to consider the musculoskeletal system. We have to consider cardiovascular system, because people with a stroke will always have other comorbidity and involvement of other systems per se. So this is basically about systems model. But whatever approaches we follow in stroke rehabilitation, we have to consider the ICF frame. It's nothing but an international classification of functioning frame. So this impairments basically, see this impairment is recent days, it's replaced as body structure and function. And then activity limitation. So earlier it was disability, now it is used as activity limitation. The handicap is used as participation restriction. So besides this, we need to consider individual's personal factor and environmental factor also. So for example, of a stroke as a health condition, people after stroke have multiple impairments. So one of them is the paralysis. Because of paralysis of lower limb, an individual can't able to walk, as well as can't able to go to work. And this one, if kind of in a country like us, see the transport is quite difficult. Individual can't cross the road is very busy. So these are the environmental constraints. If the person is not motivated, if the person has other comorbidity, so these personal and environmental factors also influence the individual taking part in daily needs. So whichever professionals, not only the physical therapists, any rehabilitation professionals would work from the point of activity limitation. See, our goal is help the patient to do their daily needs so that they will have a better quality of life. So basically, we need to identify what are the body structure and function that limit the activity limitation. So we should not approach a patient based on impairment model. So our role is not just treating the spasticity, treating the strength per se, but we need to identify how the spasticity or muscle weakness or incoordination would invariably affecting their daily needs. So this is what we need to consider. So the traditional approaches was earlier viewed as an impairment approach. The recent development approaches are viewed as an activity approaches. But whichever approaches, either it goes from left to right or right to left in the ICF frame, but we need to consider the assessing the activity and then work on whichever approaches you are familiar with, you are expertise with. So roots approach, we all know the roots approach basically works with facilitatory, inhibitory techniques. We use various modalities, sensory modalities to facilitate the muscle activity or inhibit muscle activity. This is not only just giving facilitation using sensory modalities. These approaches are viewed from a functional perspective also. For example, we do use roots approach in basic bed mobility, even sitting to standing. So we use all these tactile stimulation to mobilize the patient. For example, standing. Whereas we do use, but we may not view from the perspective of roots approach. But there is a heavy joint compression when the person stands. So there is an activity of the proprioception. We always consider about paralysis. Many times we neglect about hemi-anesthesia. People after stroke do have sensory impairment also. So whichever modalities we use, either a tactile or any proprioceptive modalities, there is some kind of feedback. So we do use roots approaches. We do roots approach in every acute care rehabilitation. Even recent times in many rehab settings, people use bed alert, some kind of an auditory feedback system that activate the motor control. So this we are familiar with. And next about the Brunstrom's approach, this is also widely used in clinical practice. We know the concept of evolution in reverse. What is this? We see the neonatal reflexes in infant, right? When the brain is maturing, they show some kind of the infants show primitive reflexes. We know ATNR, STNR, TLR, tonic labyrinthine reflex. So why these reflexes are there at preterm or at the neonatal stage? Because the brain is not mature. So these reflexes are there. Okay, these reflexes are there. They're the building blocks. So now what happens after stroke? Because there is an injury to the brain, cortical or subcortical structures, these brainstem mediated reflexes are released. That's where we say evolution in reverse. We happen to see these kind of an attitudinal and postural reflexes. When we do tone evaluation, we find a different kind of resistance from different musculatures. Depends on the position the patient is in. Sometimes patient is in prone, the flexor tone becomes more because of influence of TLR. So this we are familiar with. So these are the reflexes are elicited. These are reflexes are there. They are released basically, right? So as per the Brunstrom's, say there are certain recovery stages taking place after stroke. The stages start with flaccidity and then slowly tone builds up as means of associated reactions and attitude reflexes, and then you find a synergy basically. Synergy is nothing but a group of muscles work together to produce a movement. It can be normal or it can be pathological. But individuals, normal individuals have different kind of synergy combinations. But after stroke, they may not show different kind of synergies. It's become stereotypic. That's where we find flexor synergy, extensor synergy kind of thing. So the stages, it starts with flaccidity and tone builds up slowly. And then the individual master in one of the synergies. We know these associated reactions. Associated reactions are nothing but reflex tensing of a muscle. So here I'm resisting to sound side. You could find the evoked movement in the affected side as well. So this is called imitation synkinesis. This is again an associated reactions. These reactions are useful to assess as well as treat for a treatment purpose. The early stage, these are the reactions are the one that helps us to progress the patient from one level to another level. We would say this is from a stage 2. Here I give resistance to lower limb. So the lower limb flexion evokes upper limb flexion. So this is called homolateral limb synkinesis. The extension movement evoke extension response in the extremity. Right. So this we are familiar with. As I said, the synergy is nothing but group of muscles work together to produce a movement. So here what happens? The person is asked to take the hand to the mouth, but he couldn't show a kind of synergy that is required to take the hand to move. So here what you see predominantly a flexor synergy. That means the elbow flexors are predominant. The forearm goes into supination and then elbow goes into flexion. Of course, there are other movement component also, abduction, external rotation, right? So you could see this movement from lateral view. You could see the scapula goes into elevation and retraction. So this become stereotypic. That's where we say mass movement synergy, whereas another gentleman shows an extensor synergy, which means he has predominantly increased tone in adductors. So either patient may show a flexor synergy or an extensor synergy when the strongest components comes together. As I said, in a flexor synergy, you have flexor predominant. In an extensor synergy, you have adductor predominance. So when the flexors and adductors come together and they reinforce each other, then we say a typical upper limb flexor synergy. This is combination of both flexor and extensor synergy, whereas the flexors are predominantly influencing this posture. That's where we say the flexor synergy. And what happens? These synergies interact each other. So the strongest components keep reinforcing the other strongest component. See here, the patient is asked to take a cup of water. You look at the hand; it's open. Right now, the same gentleman is asked to reach to the cup of water, a glass of water. So you could see the reflex tensing in the hand. But whereas it is not seen then. When you observe, the hand is open. But when the person is attempting to do that, he cannot do that. But he fails to do that. So repeatedly, he uses the same fail to do And then what happens? He learned not to use this, then he used the unaffected hand. This is what the concept of learned non-use. But whereas you can see the interaction of the synergy component in this picture. Right. That moving to the stages. So as I said, the stage 3 is called the semi-voluntary stage, which means the patient has control in the synergy. For us, may be abnormal, but as such, there is no abnormal synergy because patient has control in this particular synergy. But our role is to assess whether patient can show deviation in the synergy, which means whether he can activate an opposite group of muscles to break the strongest component. For example, here you see the patient is asked to take a hand to the waist, right? And here the patient has to do supination pronation. But what that means, the elbow is flexed. There is an influence of flexor, but the patient has to learn the pronation, which means he can overcome the supinator longus. There is the biceps. So this is where you train the patient to gain some movement control. As and when the patient learns control, he can progress. So that's the concept. Now moving to 5th stage. These are the stages where spasticity start declining. So the Brunstams viewed to increase the tone because the recovery pattern starts that way. There is a flaccidity and then increase in tone. Then there is a synergy. And then synergy, when the spasticity start declining, then patient can show some kind of a movement combination. That's where the Brunstam believed that increase the tone and then decrease the tone. So here you could see the person is abducting the arm, right? When there is an abduction, what would happen? The elbow goes into flexion. So now the person can break the strongest component of the flexor synergy and could do an abduction. Then this is a little bit of an advanced level of control in a synergy. In other words, you can say master in synergy. So same assessment can be considered as treatment. So here you see, right, the person lifts the hand above the shoulder. So here the patient is asked to do supination, pronation. Whereas in the previous stage, he was asked to do supination, pronation with elbow flexion. But here he is asked to do supination and pronation with shoulder flexion. But still you can see an influence of the flexor synergy when you supinate, right? So this is an assessment. And from there are a set of protocol to treat the patient as per Brunstam's philosophy. The recovery stage 6 is the stage where the patient can overcome the dynamic spasticity. We heard about dynamic spasticity. Dynamic spasticity means when we move at certain velocity to do certain activity, then the spasticity comes in way. So when the patient can do a speed test, repeatedly he could do this kind of a movement, thigh to knee or the hand to chin. Repeatedly he could do that, then definitely he could overcome the dynamic spasticity. Then we can say that the patient has progressed to stage 6. Right? As well as we have to consider hand control also. Whatever we treat for proximal extremities, when we can't train the hand control, many times the patient fails to do upper limb activities because the hand has a largest representation in the homunculus and it is unique in human species, right? Unlike animals, we have the prehension control. So we need to consider treating the hand. So similarly, the hand also has a recovery stages. You have instinctive grasp or instinctive avoidance reaction, and then you have a Stokes finger phenomena. Which means the hand is twisted. The moment you take the hand above shoulder level, the hand opens. So we may use these reflexes to get the movement. And then the basic concept, we need to consider stability of the wrist, and then we need to help the patient to extend with the wrist dynamic stability. And then we have to train the patient for an individual finger movement. So if we could do that, then probably we can help the patient to do the daily task. Is it clear? Am I going too fast or it is okay? Excuse me? Sir, organizers? Is that fine? Am I going in the same?
This is okay, sir. This is fine. You can continue the same pace.
Oh, thank you, sir. Thank you so much. I'll proceed. Then next comes the neurodevelopmental treatment. The neurodevelopmental treatment also based on the reflex hierarchical model. But only thing is the Bobards, the founder of these NDT ideas, they said don't increase the tone, don't allow the spasticity to reach to the height. Whereas the Brunstrom philosophy, they said the recovery pattern itself goes in this way, the spasticity reaches peak and then start declining. But what Bobarts believe that if you allow the spasticity to reach more, then it's quite difficult to bring it down. So they said don't allow the spasticity to get increased. So they have come up with reflex inhibitory postures and then reflex inhibitory patterns and then of late tone inhibiting patterns. Basically, here you have to place an extremity exactly opposite to the spasticity pattern. Suppose individual shows excessive flexor synergy, then you place an extremity in the extension posture. So this is what they believe. But the underlying concept is not about placing the limb. This concept is more dynamic. Of course, if you read the articles from NDT or the instructors of NDT, they do adapt other motor control approaches also. Because the Bobarts said it's an evolving concept. The idea is you have a normal tone. From the normal tone, you can get a normal movement. So basically, they consider the postural control. They give much importance to alignment, trunk control to an extent. But what they believe, you have a good proximal control, then you will have a better extremity control. What this is, we can consider a simple movement. We have a tonic group of muscles. In other word, we say postural group of muscles. For an example, we take lumbricals also. In our hand, the medial two lumbricals are bipennate, right? The lateral two lumbricals are unipennate. So when we write a text, so how we do. So the medial two fingers are flexed, which means the medial two lumbricals are playing a tonic role. So they stabilize the hand, and then we use the lateral two lumbricals. So the tonic muscles basically should help the phasic muscles to work. So in that sense, if posture is good, it is controlled by feet forward system. It is although controlled by extrapyramidal system. So when the normal tone is there, and then you can get a normal movement. When the normal tone is not there, suppose you allow the postural muscles not to work its role, then you start activating the phasic muscles. The phasic muscles cannot generate force. They also become stiffer. So what that happens, the phasic muscle becomes stiffer and they take over the role of postural muscles. In a simple word, the tonic muscles should stabilize the segment over which the phasic muscle should move the joint. This is the concept of posture and movement. So here you see this example that we see in our clinical practices. The patient is asked to get up in a normal circumstances, and able-bodied individuals can selectively flex the upper body. But because the postural control is not there, person is using the phasic muscles. You could see very tight the rectus activity, the obliques, the multispinalis. These muscles are not working. So the person is using the phasic muscle that is meant for selective movement. So that is transferred in the leg also. You could see a typical extensor spasticity. So because there is poor postural control, the leg becomes stiff. So this is the concept. So based on this concept, they use different facilitatory techniques. So the concept of dynamic stability is, in a simple word, it's an ability of a part of a body to remain stable, so that other part of a body can independently move in a different direction or a different plane for a daily activity. This is what about a dynamic stability. This dynamic stability is there for every part, as I explained, for a hand functioning. So medial two lumbricals play a role of stability, then lateral two lumbricals will play a role of mobility. When that is compromised, all of them become stiffer. That's where we find a stiff hand. Right. So the Bobarts believed in normalizing the tone and get a typical movement. So for which use handling techniques. Handling technique is nothing but giving a correct level of sensory feedback, correct level of sensory modality, and then get the movement. So you say this is a facilitation. Facilitation means to make the movement easier. Inhibition means to stop unwanted movement. So you use certain key points. Key points in the sense you place your hand at certain part of a body, and then you get a desired movement, functional movement, in other words. That is where it is called key points of control. If you place the hand at the torso, at the middle part of a body, and get the desired movement, it is called proximal key point of control. Same thing, you use your hand at the distal part of a body, particularly in extremities, then it is the key points of control. But you can give a right amount of sensory input either at a proximal part of a body or a distal part of a body, still you can get a desired movement. In a simple term, key points of control means the way you place the part at which you place your hand and then get the desired movement. So the whole process is called handling. Right? The way you get the movement done is called handling. So here you could see I place my hands at the proximal part. You could consider this is the proximal key point of control to help this gentleman to get up. Whereas here in this particular example, with this particular picture of the beneath the bottom right, I placed one of my hand at the distal extremity. So this is the distal key point of control to help the patient to complete the supine to sitting activity. Right. See here, this lady is showing a typical flexor pattern. So my task is we have to I have to help her to take the hand to the mouth so that she can drink a cup of tea or can take an apple to the mouth. So that is the task that she has to perform using hand. But the problem is she's using a stereotypic arm pattern. So what I'm just doing here, I'm just training the hand to mouth task using a distal key point of control. Right? But this is a facilitation. But from a contemporary NDT perspective, you should not just move. You should not help the patient to move, but you have to place an object, a piece of an apple, and she should take. Then only the movement can be useful, and she also can plan and execute. But the idea is here I'm using the distal key point of control to overcome the mass synergy and normalize the tone and help her to do the hand-to-mouth task. Right. So next comes the proprioceptive neuromuscular facilitation. This is also a traditional concept, but this is quietly different from the NDT and Brunstrom's approaches. But one thing we have to remember, all these people, when they conceptualize these approaches, they discussed each other, they adapted some of the salient features from each concept. But only the underlying philosophy is quite different. But their ultimate aim is to help the patient to move. So the facilitation, inhibition, it is there everywhere. The only difference in relation to Brunstrom and the Bobards are that one allowed spasticity to heighten, others said don't allow spasticity to heighten. But all of them are hands-on approaches. Right? PNF, they believe in a diagonal patterns. So diagonal patterns are nothing but an angular movement along with a rotatory movement. Why they say diagonal movement? Even you consider our muscles are oriented that way. Our muscles are not exactly oriented in sagittal or frontal plane. They are oriented in between. So the muscles orientation also like that. So when we do a movement, so we move our extremities, in fact, our body also, the whole body also, in a three-dimensional plane. So that's where they believe that the movement to be encouraged in a diagonal way, which means involving the angular movement and rotatory movement. But remember, the pattern is not the PNF, because pattern is one of the principles. We say D1 pattern, D2 pattern we are familiar with, flexion, abduction, lateral rotation, and then extension, abduction, internal rotation. This is one pattern, right? So there is a combination of movement in the intermediate joint also, because the pattern is named after the agonist muscle contraction that we are familiar with. But the pattern is not PNF. Most often we do D1, D2. That is not PNF. The pattern is one of the principles, right? One of the 10 principles. Of course, we use resistance. The resistance is also a guided resistance. If a person cannot move, then we need to do an assistance, a kind of an active assistance. We know muscles are stronger at some range, muscles are weaker at some range. In biomechanics and exercise therapy, we learn. So when the muscles are stronger, we need to give a guided resistance so that there is a kind of a reinforcement. there is a springing of impulses to other part of the muscles, so they also get activated. That's the idea. I'm not repeating all the principles, but the important thing is PNF is not about the pattern. PNF is applying the techniques in the pattern. That of course using following other principles though. So these are the examples we know. So this is called positioning and then handling pattern. So there are different terminologies, different principles are there. I'm not telling much in detail. But in general, in PNF, there are two techniques. One is strengthening technique, other one is lengthening technique. Strengthening technique means you activate the muscle, you increase the muscle recruitment, and then you build the muscle tension, active muscle tension. And then you develop some sort of coordination also. So we know rhythmical initiation, then combination of isotonics, dynamic reversals, rhythmical stabilization. These are the stabilization techniques. What is the rhythmical initiation? Rhythmical initiation means you do an active assisted movement. When the patient can do an active movement, you give a resistance in the pattern. That is what rhythmical initiation. Dynamic reversal, what is dynamic reversal? You give a isotonic contraction to the agonist group of muscles, and then you give a isotonic contraction to the antagonist group of muscles. So you are dynamically reversing. But in rhythmical stabilization, it's an isometric contraction. That is the difference. We have another technique called a combination of isotonics. This is nothing but you do a isotonic contraction to the antagonist, followed by again an eccentric lengthening of a same muscle. A simple example is a biceps curl. When we do a biceps curl, when you do an elbow flexion, biceps are working concentrically. When we do an elbow extension with load, the biceps would work eccentrically. So there is a combination of isotonic. The same concept you have to do in a pattern that requires an expertise, because this is a skill component. That's where it's unique. A physical therapist are called skilled professionals, movement scientists, because we know how to facilitate and how to get the right kind of a movement done. Right. The next comes the motor relearning program. Until this point, we never spoke about the movement mechanics, because these were the philosophies. They go by a facilitation, inhibition, whereas the motor relearning program developed by Karan Sabgar from an Australian group, they looked at the movement dysfunction from the biomechanical perspective. So they said, don't do hands-on training every time. You analyze the movement per se, and you find the missing component, and then start training those missing component as a part practice, and then do a whole practice. Then again, you make the patient to do functioning. Then you do a training. Then if the patient can able to do this kind of a training, then you transfer this particular training task at home. So that's where we say transference of a task or a generalizability of a task. For example, simple example, sitting to standing. Right? So this is a task. The person needs to do sit to stand in a bed. So what are the components that are essential? The feet to be placed behind the knee, and the trunk should be listed forward, right? And then while getting up, the knee translates forward, and then patient activate the anti-gravity muscles, and then extend. What happens in stroke? So they will not rest the feet. The reference of stability is compromised. They will not trust the reference of stability. So they lean on the sound side, and they will not take the body also too forward. They keep the body behind, and then struggle to do getting up. So if we consider the simple task, then what we do, we train the trunk inclination itself. That is a part practice. We have to help the patient to do forward trunk leaning. Maybe in other words, we can say a dynamic sitting balance, a forward reach or a diagonal reach. This is a part practice. At the same time, we have to help the patient to do sit to stand in the initial phase. That is again a part practice. Then you help the patient to do sit to stand together. Sit to stand means the leaning forward and getting up in an initial phase. So this becomes a whole practice. Once the patient is mastery in sit to stand from a cot, then the patient has to do the same task in a chair. If the patient can successfully do that, he develops a kind of a confidence, and he also will have a kind of a planning. Then he should be able to do the same task at home. When he has to go to dining table and have dining with family, or he has to go to commode and have a commode task. In other words, he has to take part in some of the function. He should get inside an auto and do the simple task. These are called a transference of a task. And another example I can give, I can run through this. Stance phase. We know hip extension is a component in the mid stance, and then ankle dorsiflexion is a component, which means from an initial contact to the mid stance, the hip extensor should contract, and then ankle should go into a dorsiflexion, which means the plantar flexors should eccentrically control the excessive anterior translation of a tibia. This is the biomechanics we know. What happens in a stroke? Imagine the ankle goes into plantar flexion. They develop a plantar flexor stiffness. So now what happens? The tibia will not move forward, right? So when the tibia is not moving forward, what happens? The plantar flexors become stiffer. The plantar flexors at the proximal attachment, it keeps pulling the knee, and they develop a knee hyperextension, genu recurvatum. And the genu recurvatum, they develop what happens? The hip goes into flexion. So over a period of time, the person develops hip flexor tightness, excessive mobility in the knee, that is a knee hyperextension, ankle plantar flexion. Now the patient will do a same kind of a circumflexion gait because he cannot clear during the swing phase because the leg is longer and there is no flexor control also in the knee. So he will do a circumflexion, which means using the momentum, the leg goes like a pendulum, right? So if we consider this one, there are multiple missing components. One is about the dorsiflexion. If you view the dorsiflexion, it can be from the restricted plantar flexors. So then we need to do an elongation of the plantar flexors selectively, right? And then we need to consider elongating the hip flexors. Not only the hip flexors, we need to strengthen also the hip extensors. So this kind of biomechanical approaches, if we go and train them, and then again we have to help the patient to do the walking, right? That's how the MRP concepts work. Now people say MRP concept is outdated, but the recent terminologies from recent evidences, people say task-oriented approaches, task-related approaches. There are different terminologies, but all of them are same. Every approaches from a recent development per se, they have a different protocol, set of protocol, but the concept is same. You analyze the function as a whole, identify the missing components, and then train them as a part practice. Then you train other missing components as a part practice, combine them as a whole practice, then transfer the training back home in a real life situation, right? Fine. So far we discussed about some of the approaches that are helpful for extremity functioning. Right? As a PT, we most often we deal with treating upper limb, lower limb for arm functioning, and then lower limb for standing and locomotion. But there is one important aspect that we most often miss out. We are always concerned about pyramidal system. We are always concerned about upper motor neuron lesion, cell spasticity, and the spasticity mediated dysfunction. What about extrapyramidal system? From physiology, we know the extrapyramidal system. There are many, reticulospinal, vestibulospinal. There are many systems. Their role is maintaining the postural tone. When there is no postural tone, then the pyramidal system also fail to do because they have to work harder, right? But the pyramidal system role is for, right? When the postural tone is not there, and the pyramidal system also would play a role of an extrapyramidal system. So this is very critical, right? So see here in this particular example on the right side, right? So I'm just palpating, and you could see there is no resistance felt, which means the tone is very low. So what I'm trying to say, upper motor neuron lesion not only results spasticity, it also results low tone, hypotonicity in the tarsal musculatures, particularly these oblique musculatures. So we need to consider this also. And another aspect, there are different examples, different explanations. The torso is controlled by bilateral neural innervation. As a PT, we are interested in biomechanics. See, unlike upper limb muscles, most of the torso muscles are attached to fascia, linea alba, right? And if one side is paralyzed, other side will pull. I mean, they also should have some kind of a stability for an ipsilateral side to work, right? So the biomechanically, both sides are paralyzed. or both sides are not showing a right level of control. Other aspect we learned in anatomy, serratus anterior interdigits with obliques, and then we learn tensor fascia data. So these core muscles have a capacity to translate the force to the extremities for function. Right. So when the idea is when the postural tone is low, when the trunk muscles are weaker, showing a hypotonicity, it influences the extremities for upper limb functioning and lower limb functioning. Right. So what is this? I said about trunk muscles. We can say a trunk performance or a control. In a simple term, we can say trunk muscles are important to maintain a body alignment and also allow a sufficient amount of weight shifts, either from an upper body or a lower body, during self-initiated perturbation or external force-induced perturbation. Self-initiated perturbation means when we move, we have to maintain alignment and the muscles also should work appropriately. External force-induced perturbation means when we walk in an uneven terrain, or when we walk in when we are standing in a bus, there is a perturbation. So our body should react. Right? So this is the control. So trunk control means the ability of a trunk muscles to maintain alignment and perform the selective movements during self-initiated and external force-induced perturbations. Right? So you can refer this paper, one of our papers, because this is an interesting one to do a trunk evaluation. Most often we don't do a trunk assessment. There are a couple of assessment tools and treatment options are available. Those who are interested can read through it. Okay, so we have extensively worked with trunk rehabilitation in stroke recovery. But what we observe, for considering our scenario, we need to view two aspects. One is about balance capacity, other is about the balance confidence. Balance capacity is the ability to maintain our center of mass within the base of support. This is the balance capacity, that ability to maintain a desired posture. Balance confidence is about the perception, how confident we are on our balance. Because this is quite critical. Because we need to go to mall, we need to go to a market where people come and then nudge you, they bump you, then you may lose balance. So individuals with stroke have a fear of fall, so they don't have a right level of balance confidence. So we need to always consider balance ability and balance confidence. So balance confidence will come when they trust their limits of stability, when their balance capacity is better, when their trunk performance is better, when their motor performance is better, they will develop a better balance confidence. In another work, we found a causal relationship between the trunk control muscles in relation to with the balance confidence. We used activity-specific balance confidence scale, where you basically measure the balance confidence during many indoor and outdoor daily activities. Right. I'm not going much in detail. How can you train a trunk? There are a lot of protocols available recent times. There are many systematic reviews are there. Those who are interested can read through this training. It is useful. You can always incorporate this trunk training along with your extremity rehabilitation. One way is you can use a standard plinth to train a selective trunk move. See, the trunk training is not just moving. So you have to help the patient, or you have to activate the muscles, selectively control either from an upper body or a lower body. This is one concept, right? Trunk training. You can use either a plinth, or you can use any unstable support medium, a physio ball, or any wobble board, right? So what the wobble board would do, there results a postural perturbation. The muscles should work against the postural perturbation to maintain the desired posture, right? So there are a lot of protocols there. I'll run through this. These are some of our papers. Those who are interested can read through them, right? And one more aspect, I said at the beginning, a dynamic stability, right? What is dynamic stability? It is an ability of a body part to remain stable but active, right? So that other part of a body can move. But consider if there is a pelvic instability. Why there will be pelvic instability? When abdominals are weaker, the pelvis tilts excessively forward. When the gluteus are weaker, the gluteus also the common muscle that is weaker, the lumbar spine will go for an excessive extension. And then what happens when the hip flexors are when there is an anterior pelvic tilt, the hip flexor has become tight. We know from a biomechanics the muscle cannot work efficiently neither in a shortened nor in a lengthened position. Then how the hip flexors would contract to swing the leg? No,
Yes, ma'am.
it becomes inefficient.
Please tell me.
So the person would do a hiking,
Hello.
excessive hiking, and then do a circumflexion. There are multiple explanations. So this comes from instability. This comes from proximal instability, because this is not a new concept. Only musculoskeletal conditions people do use, but this is there in stroke rehabilitation as well. So you need to consider the dynamic stability at every point. In simple word, you can consider a synergy stroke, right? Wrist, for the hand muscles to work, FDP, FDS to work, the wrist should be stabilized. There is this kind of a synergy. This is what, in a simple term, about the proximal dynamic stability. Work on proximal dynamic stability. Everywhere you find an instability and movement related dysfunction, it helps you, definitely helps you. Right. And right. So these are the so far we discussed about traditional approaches and some kind of a recent development using the traditional ideas, traditional concept ideas. There are a lot of recent developments have happened. So much of development happened in literature. I'm not going much in detail. I'll just give you an overview. I'll introduce these concepts. You're familiar with constraint-induced movement therapy. It is very well used in hand rehabilitation. People, so this is the flow chart. If there is an injury, there is a depression in the motor activity, the person start using the hand, it becomes insufficient. The patient experience not able to do. So it's a kind of a failure. The patient perceives behaviorally failure, he considers failure. Then he will start using an opposite hand. That's where the concept of learned non-use. Right. So if anyone is interested, can read constraint-induced movement therapy. There are very, very nice papers are available. What we do in a constraint-induced movement therapy, you constrain the unaffected hand. You constrain the unaffected hand. So you give an opportunity for an affected hand to use. Right. So when the patient repeatedly use, it's a kind of a forced use, and you have to use these principles: use dependent cortical rehabilitation, activity dependent plasticity, that requires an intensive training and requires behavioral shaping. What is behavioral shaping? You have a target, a task. You have to design a protocol so that the person would undergo an intensive training so that he will meet a target task. That is what a behavioral shaping. This requires intensive training, 6 days, 6 hours a day for many weeks. This requires intensive training in order to get a use-dependent cortical plasticity to overcome learned non-use phenomena. Right. So there is a transference of a task. The person has to do this task in a home as well. Fine. Right. So this is very interesting concept, but for which the patient should require at least 10 degree of wrist extension and 10 degree of hand opening, some amount of elbow extension. These are the ideal candidates to go to a constraint-induced movement therapy. Right. So there are other ideas, mental imagery or an action observation therapy. Action observation therapy means from a third person's view, the stroke patients will view the normal movement. He will regress and he will perform. See, these mirror neuron systems are ready to activate when you do a physical movement. These concepts again go along with mirror therapy also, because you have EMG biofeedback and then balance training, functional electrical stimulation, EMG guided training are there. Partial body weight support treadmill training is there. And then recent time TDDS, transcranial direct current stimulation, transcranial magnetic stimulation is there. Virtual reality, so much of development has happened in virtual reality, augmented reality, immersive reality, so much is there. One can read through them. There are a lot of developments. So there is a lot in it. So I think it's already 10:30. So I can wind up my presentation. Thank you for the opportunity. Thank you for listening.
Dear participants, Now the floor is open for questions. Any questions? You may ask the resource person. Sir will be kind enough to redress your doubts.
So I can take a couple of questions. Thank you for patient attendance. I'll take a couple of questions, please.
I believe few of them have raised their hands. Any
Right, sir.
participants? Yeah. Your questions, please. Yes. Shama
So
Sherin. Yeah.
you can unmute and you can ask a question. I'll try to answer.
Yes, please. You can ask your questions, please.
You can ask. You can come forward. You can ask question. If or otherwise, if there is a text, chat box is there. You can type as well.
Yeah, I'm seeing Mr. T. Subramanian and Mr. Vipul have raised their hands. Yeah, you can please ask your questions. No? Because we are running short of time. In case if you don't have any questions, or in case later if you want to ask some questions, you can contact the resource person through his email. Thank you so much, sir.
Yes,
it was a wonderful presentation, because usually we see the presentations with a number of viewers. When your presentation started, we saw around 86 participants was hearing, but as it progresses, we would be able to see around close to 150 people were hearing your talk.
My
So
pleasure,
nothing
sir.
has left, but everyone is slowly adding up. It was a wonderful presentation, excellent presentation. It was an opportunity for us to hear a lot about neurotherapeutics on physiotherapy. Thanks for joining.
Thank you, sir. It's my pleasure. Thank you. Thank you so much. I'm happy to answer your doubts. You can drop me any doubt. You can access to my mail, karthikbabu78@gmail.com. You need any couple of papers, I can share with you. I'll just.
Good morning, sir.
Yes,
Good morning, I'm Subramanian. Hello, good morning, sir. I am Subramanian, professor from Robert College of Physiotherapy.
Yes, sir. Please.
Yes, sir. Small doubts. Constraint-induced movement therapy is equal to eclectic approach, sir. Similar to eclectic approach or different, sir?
Sir, I'll just clarify. Your question is whether constraint-induced movement therapy an eclectic approach.
Right? Is similar to eclectic approach or it is different?
Okay, sir. As such, eclectic is the terminology, sir. Eclectic means
Yes, sir.
we use a combination of approaches, right? So sometimes it's a kind of a sandwich. But we usually don't use approaches that way. If we have many techniques in our kitty, many approaches in our kitty, we also expertise in certain approaches. So we assess the patient, we understand which kind of an approach is best suit to the patient. So we will give only those approaches. Then it is eclectic. That means we can use any conventional traditional approaches along with CMT. That's okay, fine. Because CMT give you recommendations.
Yes, sir.
Right. Use that recommendations, and you can use any other approaches. Right. So we can definitely use, and we can claim as an eclectic approach. But it is not combining all the approaches. But you can combine.
Okay. Combine. Based on the inabilities, sir. That is the eclectic
based on our expertise and based on the assessment.
Okay, the principles of eclectics is the unaffected treating. We are treating the unaffected limbs, sir. This constraint-induced movement therapy is equal to unaffected limb or affected limbs, sir. More concentration in unaffected.
No, it is about because the patient uses an affected hand and he finds difficulty, so he starts slowly, neglecting using the affected hand and start using the unaffected hand. Right. Suppose for me, it's after stroke, difficult to take a cup of tea. It's easy for me to take the cup of tea from an unaffected hand. So, but
Okay,
though I
okay,
have a
okay.
capacity to use, I don't use. So
Oh.
you are constraining my unaffected hand, right? And you are forcing me to use my affected hand. That's what called forced use. Learn non-use through shaping principles. You force me to use the affected hand. That is where the concept of forced using and shaping.
Oh, okay, sir. Fine, sir. Thank you, sir.
Right.
Thank
Right.
you.
Yes. Post. Right, sir. I think we are running short of time. Dr. Goswami sir is waiting. Even I am also keen on listening to Goswami's lecture. Any doubts you can drop me to my mail.
Yeah.
I just have texted my mail ID. Yes.
Yeah.
Thank you for the organizers for giving me opportunity to interact with the excellent physio community. Thank you. Thank you so much.
Yeah, thank you, Dr. Karthik. It was a wonderful presentation from your side. And dear participants, Dr. Karthik Babu has put his email ID on the chat box. Any queries, any doubts, you can have a mail, send a mail, and he'll be very happy to respond to you. Thank you for your sir.
My pleasure,
For
sir.
your beautiful
My
presentation.
pleasure.
And
Thank you.
participants, thank you for your patient hearing. And this program is still continuing. And we have one more resource person, Goswami sir. It is always a saying that goes like if you are physically challenged, you lose access to places, and in case if you are having if you are challenged by communication, you lose people, you lose access to people. So that's how it actually goes. So in stroke, we actually have both the things. You have both the physical component as well as you have a communication component. So a person who is affected with stroke has lose access to places, also lose access to communication, also to communication. And communication is a very important area. Me being a privileged person or being one of the nodal officers of CRC Andaman, I used to, people said, and I have experienced this, people, when we are going to Andaman and Port Blair, they took us to the cellular jail and they showed this place. And in that place, we are able to experience, or the people are explaining about the place. So one of the highest punishment is being given for prisoners is to keep them in a solitary cell. You will be given food, you will be given all the privileges, but you will not have any people to communicate. And after few years, these people, since they lose communication with the external world, they become insane, they become mentally ill. That is the punishment that is considered the highest punishment being given to people. So communication is a very important area. So we have a highly privileged resource person, Goswami sir. I am so privileged to introduce him because he is our academic council chairperson. Being the coordinator of an academic council, I always have the privilege of introducing him. Sir is a proud recipient of Dr. C.V. Raman Fellowship Award. He is a renowned speaker, a researcher, a clinician who is having a vast 22 years of experience in this field. Uh, he used to guide so much of research scholars because we used to see his updates. Many of them, many of the renowned people are the students in the field of speech, hearing, and communication. And he is always a pillar of support to NIEPMD for any of the academic areas. So in case if NIEPMD has any doubts on academic areas, any constraints, we used to approach Goswami sir, and he'll be ready to help us in any of those. He is constantly with us for the past 3 years as academic council chairperson. It's my honor and privilege to welcome you, sir, and all the participants are here to hear your overwhelming talk on this subject. My small request to all the physiotherapy colleagues and students, it's a multidisciplinary approach. So please do hear and hear the expertise of sir, because we don't work in silos. We work always as a team. So you should also understand what is the component a speech pathologist looks across. That's very important. We don't always look only physiotherapy. So along with the speech pathology colleagues, physiotherapy colleagues, please do continue and hear till the end of sir's lecture, and any doubts sir will also be very happy to clarify. Thank you, sir, and welcome you for this program. Thank you so much. Sir, you're not audible, sir. I think it's on mute.
Sir, can you hear me now?
Yes, sir. Yes, sir. Loud and clear, sir.
Okay. I'll just share the PPT. What is the problem now?
Yes, sir.
Why I'm not able to share my window? Choose.
Pardon. Yes.
Share screen and the entire window.
Sir, I'm only seeing the screen, but I'm not seeing my. 1 second. Entire screen. Okay, perfect. Entire screen window. Okay. Perfect. Sorry. Okay, I could get it. Okay. Thank you very much, sir, for the introduction. I just wanted to tell you that I will not talk to you about very specific perspective, what we see in persons with stroke, consequence of aphasias. Sir, am I audible? Am I
Yes,
okay?
sir. Yes, sir.
Okay.
Loud and clear, sir.
Perfect. Okay. I'll talk to you very generic part, and any specific perspective you have, I'm open to discussions, and whatever I know, I'll try to share my views.
Sir, one small request, sir. You can keep it in the presentation mode. It will be okay, sir. It's not in the presentation mode.
Okay. Now, sir?
Yes, sir. Still in the not in presentation mode, sir. It's not changed.
Once it divides. Stop sharing. Let me try once more. Now is it okay, sir?
Now it's setting, sir. Actually, it is setting the mode.
Now is it okay, sir?
Okay, sir. Now still it's not in the presentation, but fine, sir. We can continue with this in case.
Sir, what do you mean by presentation, sir? It is not in a full screen?
No, it's not in the full screen, sir. It is in the.
Where else it comes, sir? Because
Here, sir.
is it okay now? Or if it is not,
But
you
sir,
can just tell me.
it's visible, sir. In case it's fine, it's visible only, sir. Okay, we can.
Okay. Because I don't know, because this is what or any other scheme is there where we go it, because usually when you put it, it comes. Okay, anyway, sir. You let me know, sir, if it is not visible or any queries are there. So this is also a communication problem. Okay. Thank you very much, sir. So what I will talk to you about, I'll just give you briefly that because it's a stroke week. So we will look more prevalence from a stroke, what it can cause and how best way with the symptoms you notice, or as a general, what can be its characteristics and what are its management approaches. So all of you know that it is nothing but it's basically the brain supply is cut off for some time. Okay, it's not even hours, we just say for few seconds, for few minutes. And depending upon the impact of the blood supply, you can have either a full-blown stroke, or you can have a partial block, or you can have what we called as, there can be ischemic or there can be hemorrhage. Ischemic is nothing but when the blood supply is not enough, like what you see in anemias. Hemorrhagic is when there can be burst, so which is very common. But ladies and gentlemen, remember it that there is a variation in terms of ischemic stroke as well as hemorrhagic. Sometimes a person gets an ischemic stroke which can last from few minutes to few hours and then he recovers back. But usually in hemorrhagic stroke, the recovery will take time. Okay, so whenever a person is having hemorrhagic stroke, he or she will require a medical attention immediate. But sometimes in ischemic attacks, the person may not be aware about that, and as a result, he will have the issues. That's why we always say that God always gives us some time. Okay, so whenever someone gets a stroke, he or she gets some time in order to what you call as, this is a precaution that you better go and get a medical assistance, but somehow or other how we miss it out. So usually it can be a transit or it can be a what we call as a rinse. So depending upon the blood supply, for how long the blood supply has been disturbed. It's similar to that what you see in your electricity also, right? When there is electricity failure, so you can have a problem at the fuse, or it can be a problem at the main, and fuse you can restore the electricity in a short duration, and when there is a electricity failure at the main place, definitely it takes. So same things happens in stroke also. So it depends upon how much time it takes to restore the blood supply to those areas. So depending upon that, the revival, the survival, the features, the associated issues, what you see in persons with stroke will have, it's not that all persons with stroke will have aphasias, all persons with stroke will have hemiparesis. No, it all depends upon how much time it has taken, how much damage it has occurred, and how early the intervention has been taken place. So please remember one thing, that the mortality rate of stroke has come down, and as a result the incidence and prevalence of stroke has increased thanks to the medical field. And that's what I say, the role of allied health professionals such as speech language pathologists, OT, PTs, it is going to be more robust. Our need and demand from the patient, from their caregivers is going to increase because survival rate has improved, but disability associated issues have increased. So as a result, it is our duty, it is our responsibility that the life what has been saved, we convert that life into quality of life. We convert that life into life satisfaction index. And that's how we have to move. So it's nowadays also you look into that, it's not the life which is important, it is the quality of life. It is the life satisfaction index which is more important. And this quality of life, this life satisfaction index gets disturbed, gets hampered once a person is having a disability consequence to the stroke, and this is quite prevalent, and it is going to increase, and it is going to increase across all age groups. Please remember it, that I see a patient as early as 18 years, I see a patient as young as 21 years. So incidence is going to increase, and it's also going to test our skills, it's also going to test our patience. So after stroke, what can happen? Once physical activity can get affected, physical fitness, communication, vocational skills, and all those things are nothing but it affects your activity and participations. So epidemiological changes also, when you look into before 2000 onwards, before 2000 or 2005 onwards, we used to say the incidence of infectious disease was very high. That's what we looked into, more of communicable disease. Other than this COVID, there was no other communicable diseases which has got a major impact on the brain, okay, which could affect. But nowadays, there is a shift, what we call as non-communicable diseases such as stroke, cancer, cardiovascular, metabolic conditions are going to increase. So as a result, individual will have more impact on their quality of life, on their life satisfaction. So when I say quality of life, it other than the life, it involves everything, starting from a grooming to getting to a vocation, to getting back to work, to be an independent or a productive member. So what I'm trying to say is that there is a shift, transition shift has taken from epidemiology. So we need to be more robust in our clinical approach. We need to be more robust in our research approach. We need to be more robust in our academic approach so that we can deliver quality services to improve their productivity. So it has been reported that 1 out of 6 person, okay, the world's second leading cause for death is 26 in 2 decades and produced staggering 177 increase in. So there is a possibility that this number is going to increase, and it has reported that 1 out of 6 person is at risk of having this stroke. This is the number which is alarming. So now the trend, when we look into the trend, has moved from developed to the developing countries. Developed countries, the stroke has been brought, the impact of the stroke has been brought under control. It's not that there are no strokes, but the impact has been brought down, because you will understand that there is something called as tissue plasma antigen therapy, TPS. So in developed countries such as US and all, the TPA, every medical professional is able to inject. It's nothing but a dye, and which clears the blockage, especially when someone is having a transient stroke.
Sir, excuse me.
But not the hemorrhaging. So it's something like clearing the drainage.
Sir, excuse me, sir. Sir,
Yes,
the
yes.
slide is not changing, sir.
It's not changing.
Yes, sir.
Is it?
Now it's smooth.
Now it has moved.
It has moved?
Yes, now it has moved.
Okay. So is it okay now?
Yes.
Okay. Okay. Now is it fine? Sir, is it fine?
Yes, sir. Now
Okay,
it's fine, sir.
okay.
Thank you, sir.
So that's what we are looking. The incidence is going to increase in countries like developed countries. So because of this tissue plasma antigen therapy, it is very robust, and most of the medical professionals are trained to use this TPA, and as a result, they clear that block. Okay, it is nothing but clearing the drainage system, right? Like in our water source, in our houses also, the water gets blocked. So they clear it out. So once that is clear, the person can walk. And hemorrhagic also has come down because of what they call it as their medical, their health issues, plus in terms of their lifestyle also, they are moving away from the typical of Western life to the Indian lifestyle, but we are becoming a vice versa. So usually they go for their annual health checkup. Okay, but in India, usually we don't go. Okay, usually we don't go. I'm not saying everyone, but usually most of us we don't go, and there are reasons for that. That can be n number of reasons. So incidence of stroke in Western countries, developed countries have impact, but incidence of stroke and its impact in developing countries like South Asian countries, countries like India, Pakistan, Bangladesh, it is going to increase, and it will increase. The reason is we have better medical facilities. Okay, we have better medical facilities, but I wanted to state one explicitly that though we have got good medical facilities, but these are only revolving around medical, and that is life. So most of the places, I'm not saying all, but most of the time what I have seen I have experienced that medical fraternity fails to refer patients to allied health, like such as speech language pathologist, physiotherapy, OT. They do not emphasize, they say, look, he has survived it. But the consequence, what most of them don't tell, most of them don't convey to them. And as a result, the overall burden on the family is increased. But that's not so in developed countries. Plus, their insurances, all their services are covered under insurances. But our services, till the patient is in hospital, they might cover it in big, but otherwise our services are not covered. And that has taken a big toll on the overall progresses, overall quality of life, as well as overall life satisfaction of these individuals. Well, something is okay. So now the slides are moving.
Yeah.
Okay.
Yes,
so
now you are able to see the risk factor slides.
These are the risk factors. Basically, when someone is having stroke, who all are risk factors? So let me look at the factors which can account to 80 to 90% of stroke. That means we can control, right? These are we call as the modifiable factors. So modifiable factors is like high blood pressure. Someone is having high blood pressure. If he takes medication on time, he does what you call as good physical activities. If he has got a control on his diet, if he does not smoke, and there is no increase, there is no abnormal body mass index, that is obesity. So you can control high cholesterol levels, you can increase your blood pressure, you can control your obesity, you can control by doing your physical activities, or you can have good physical activities, you can have a good diet. And if you do not have good habits of smoking and drinking, because these are the factors which we have 100% control. But thanks to the advancement in the technology, our diet, our physical activity, our body mass index, our habit of smoking, drinking has increased. And this has increased in young population, which is a sign of worry, which is a sign of concern. But these are easily modifiable. If can be modifiable, 80 to 90% of the stroke can be prevented. As a result, 80 to 90% of consequence of the stroke can also be prevented. The other factors which we can also modify is in terms of the factors which we cannot modify. Okay, these are something what we call as age and gender, right? Age will increase. I think other than the women, all men increase by their age. Gender, both the genders are proven, so it does not discriminate it. Anxiety, depression, and high stress levels, which most of us do not communicate face to face. We are more on what you call as Facebook, WhatsApp, Instagram. So as a result, the stress levels, the depressions, the isolations, family history and genetic, people who have, they are at more risk. Living or working in the areas with air pollutions, people like who are staying in bigger cities, the pollution, air pollution is one of the factors. Which other medical conditions, such as your lifestyles, someone is having other like diabetes, hypertension, race and ethnicity, that is not known in countries like India, but Western it is known. Viral infections. Now, certain viral infections like especially encephalitis, meningitis, even in younger as well as in elder people, we are at prone to have a stroke. People are having a stroke. So when you look into the symptoms, what we see, I think Sir also talked about what we see, you can have, depending upon the area which is affected, but what you see, there can be a paralysis on one side, there can be loss of communication, there can be slurred speech, the speech might disturb, loss of muscle control on one side, sudden loss either, or it can be either partial or complete, we can call as even, there can be neglect, there can be hemianopias, there can be loss of smell, there can be a loss of taste, and there can also be issues with reference to the swallowing also. So there can be a lot of factors which can contribute. So there can be issues with reference to blurring of vision, loss of coordination, nausea, seizures, means you name it, an individual can have it depending upon what he or she has. So basically they have been talking about, and this has been mostly advocated, that be fast. So these are the easiest. So we can just say if there is an imbalance, if there is a blurring of vision, if one-sided weakness or drooping is there, arms or leg weakness you find it, or you find numbness, issues with speech, and time. Basically they say if these three features you find, one needs to go for an emergency, that is a call to the medical services. That's how we say it, and early treatment is the best treatment. So the complications what we look into is, as a consequence, it can have long-term disability as well as death. Okay, but the incidence of death is low because thanks to the medical advancement, they are not allowing people to die so easily. Yes, complications can be there. So we can prevent it. That's what I have repeated, based upon the lifestyles, based upon our what you called as food habits, based upon our control on the various conditions, like you can manage your health such as your diabetes, hypertension, sleep on time, change your behaviors, which can take care. And people have been saying that if we can avoid drinking, smoking, and consumption of soft drinks or any contaminated food, which I think is quite increasing. But all these factors, when we looked into all these, that's what I say, control is basically, I'm not a strong believer of the medical model. I'm a strong believer of the biopsychosocial model. So what I try to say is that it is your activity and participation which is taking it back. Okay, anything, whatever the damage has taken place is done, which cannot be reversed. But we can definitely control the activity and participation, provided the environmental and the contextual factors are quite prone, quite restrictive. So when we have a stroke, okay, so the stroke recovery, when we look into it, is basically recovery should not be looked only from life. Okay, recovery should be looked, that's what I'm saying. I don't look into only a life, I look into quality of life. So focus on the benefits, patient access to appropriate medical and rehabilitation. That's the first right. Okay, survival is the one that is being paid much attention, but very less attention which is documented and given for reintegration once a person is having aphasia into work and family life is very, very low, especially in countries like India. So by focusing on the perspective of person with aphasia and their families is a very important. And that's what we talk about the inclusions. That's what the ICF model is talking about, that look, whatever has happened is happened. It is your activity and participation. If we can get back the person, improve his activity in terms of social, in terms of vocational, in terms of his talking, walking, grooming, his participation will improve. And this can be by environmental factors. Environmental factors can be at workplace, in the society, at the nation level, at workplace. Personal factors such can be, it can be in terms of motivation, finances. Okay, environmental can also be in terms of accessible, affordable services, which are clear. So whatever has happened, we are not going to reverse it back. But this is our 100% under our control. And this, I think if we do it, we will be doing a big service to the person with aphasias and their family members. So usually when you look into what is the recovery pattern, so recovery pattern is once a person is having a stroke, okay, we will see that this is a stage of grief also. So we move from denial to acceptance. Initially, people don't accept it, that okay, he had a stroke, they may not accept it. They will say, okay, he will revive back. Once the medical fraternity clears that he had a stroke, the denial moves to anger. Why he got it? The family members, the caregivers, the person who is affected. Then the bargaining comes. Yes, okay, he had a stroke, he made it, he survived it. Once they know he survived it, he made it, then comes your depression. That look, yes, he has to live with this. He has this problem. And then comes to the acceptance. So what happens? You will, a family as well as a person moves from shock to turbulence. And then once the acceptance is there, it seeks help. So my understanding, my perspective is, once a person had a stroke, it is the sole responsibility of the medical people to aware them, to make sure that person, family and person accepts it. Because the earlier acceptance, and then they say who are the people who can provide help. That's what it looks into, that seeking help for physical well-being, for mental well-being, which is more to improve their activity and the participation. This is what I have been looking into, that when you look into the recovery of the person with stroke following having aphasias, it's a primary. So you have very high emotions. That is the emotions of the family as well as the stroke victim is very high, because it's survival. Initial stage survival is the main. So that's why the doctor will say you wait for 48 hours, you wait for 72 hours. And once he makes it, they say, look, he has survived it. So this is a state of life and death. And then what happened once he has made it from ICU to the middle state, where they say from moving hospital to home, medically he is stable, life is out of danger, the emotions of the family and the patient takes a backseat. Survival, so that's why the emotions at that level takes a backseat. And this is what they do. Now it moves to the second phase. Once a person moves from hospital to back to home, the worry starts. Finances at hospital, somehow by beg, borrow, steal, or in terms of whatever insurances, it will be covered. Okay, in the primary stage, somehow it is managed. But the services which is provided by allied healthcare services in terms of physio, in terms of occupational speech, okay, or a psychological, it is a concern, and it's a serious concern. And that's a serious determinantal for their overall well-being as well as improving their life. That's what I'm trying to say, that stroke leading to cause of aphasia, life is larger than aphasia. Please understand, it is not aphasia which is mere, but other than the aphasia, still there is a life. So life with the family, life with the friends, life with several things. So what you see in aphasia is, due to stroke, you see only difficulty in understanding, speaking, reading, writing, and all. But as a consequence of that aphasias, what can happen? This is the practical things which happens, and which as a result we find several issues with the families. There can be impaired relationship with family and friends. Few days till you are there in ICU hospital, everyone will come, everyone will sympathize. But then family and friends take a backseat, that someone might ask money, someone might ask some favors, loss of self-esteem to the person, motor problems, loss of job, loss of independency. Lot of people are losing job. The firms, the organization, they say, no, we don't want to recruit them, we don't want to retain. Other consequences can be financial dependency. Person who was a kingmaker, who was taking care of the family, now he's dependent on finances, either on his wife or kids and all. Difficulty to attend social gatherings. He was a person who used to go out, meet friends, talk, walk. Acceptance by self and family. Families, there are, I have been knowing nowadays, I work with reference to the families in terms of court and medical legal cases, where families say that we don't want to take care of them. They have what you called as deserted him. There have been family fallouts. There have been issues where people have said that, look, we cannot take care of you. We feel it's a burden. There can be other health conditions such as seizures. There can be deterioration also. There can be people who can have multiple strokes and it can lead to dementia also. Inability to pursue hobbies, marital issues, especially when you looked into the young couples. I have been receiving this issues that, okay, can we go for a child? Can we have a child after the stroke? So I have been trying to tell them that, look, there is nowhere in the book it is written that the people become sexually incompetent. But the sexual incompetency in the court of the law has taken a big drop. Okay, there have been cases where women have gone to the court and said, because he's sexually incompetent, I'm giving a divorce. That's a serious concern, and that's what I'm saying. We need to keep our communication open with the family members. That, look, each one of us is prone to have. So let us not desert them. Let us care. Let us have a concern and hope they will recover. Equally, we are finding about nowadays. I looked into the abuse. The abuse can be from the caregivers as well as from the professionals. Abuse can be in terms of physical abuse. There can be sexual abuse. There are also materialistic abuse where people have got it signed on their document and have misused these individuals. There can be a neglect. The neglect can be on part of person with aphasia that he does not want to. He can have a lack of empathy, or there can be neglect from the family members because they do not have resources. So these are the issues which we looked into. So what we need to do is we need to treat each and everything. So that's what I'm trying to say. Aphasia is bigger than, okay? So it's a bigger consequences. So we need everyone. It needs starting from a neurologist to a medical social worker to the family member to the OT, PTs, SLTs. Everyone needs, and we need to work in a synchronous way. All of us work, but we work all in isolation, bits and pieces. So when we do clinical bedside evaluations as a speech language pathologist or as an occupational therapist or as a physiotherapist, I'm not saying you have to do it, but look that if you see a person who has not been referred to a speech language pathologist, if his communications are bad, then we look into that. Nowadays, before communication, we look for the swallowing also. That if there are issues with the swallowing, we need to assess it. If he is not able to eat well, if he is not able to swallow medicine, if he is not able to drink what you call a semi-liquid or a liquid or a solid. There are several cases which we have seen that there can be an aspiration and the patient is at risk. Yes, people say that he's able to swallow, he's able to take to the tubes and all those things, but that's a secondary. But is he able to take anything through oral? If not, we have been telling, this is the Western norms which have been saying that every person with a stroke needs to be assessed for the swallowings. So we have been looking into, these are certain what you called as parameters where we look into that. Once the condition is medically stable, look for oral mechanisms, observe for any poor dentition, mucosal lesions, or oral thrusts, or any excessive or inadequate saliva, because these are the things which can affect his swallowings. So once a person is stable, once a person is little stable, and that's why in Western and all, even soon after the stroke, they say look for the swallowing, because in case the medicine can be given through the oral means. We also look for a bedside evaluations where we need to look for expression, comprehension, repetition. These are the terms. So in case simple, by asking what's your name, can you point to this? Okay, can you show me this? Can you name 5 items? Okay, that's the biggest things if they can do it. Or where are you? Is your name so and so? So if you can look for a very basic things, like is this your name is this? Is your name Mohan? Are you in hospital or are you in hotel? Okay. Can you name 5 animals? So what happened? That will give a lot of information that okay, person is able to communicate. Is he having a orientation to time and space? That will give you that okay, is his cognitive, his communication skills are good or bad. Similarly, what we do is we also give lot of approach in terms of communications. So we always say that the initial stages, it is very important that all the professionals communicate with each other. We have a regular update because there sometimes if there is a silent stroke, the condition might be. We need to introduce both the direct and indirect. In the initial stages, even if you do not have a speech language pathologist, please make sure that the nurses, the doctors, the other professionals, they communicate with him. And if nothing, if his communication is lost, use what you call as writings. Writing can be used. Yes, no questions can be used. Okay. Ask him to listen to music. Put them in case if there is a place where there is news are going on, let him to listen to the news. Let him get active. Do not put him in the bed. That 24/7 sleeping. Once he's little alert and active, please put certain activities so that the neurons, so that the neuronal levels, whatever reorganization when we can do it, if we do extensive repetition, if we do extensive stimulation, it can make a lot of difference in their life. Communications, we can use, try to eliminate several distractions. For example, when you are communicating, always use face-to-face. Avoid distractions like radio, TV. Use short and simple sentences. Speak slowly. Ask one question at a time. Use yes or no rather than open-ended. Is your name so? Are you in hospital? Repeat messages using the same wording. Do not rephrase it. Avoid interrupting the person when he's communicating. Encourage the person to talk around. Describe it. Say it. Certain tips can be, one has to be very, very active listener. Listen to him, read his body language, what he's trying to say. Make sure you are an active listener during conversation. Make a good eye-to-eye contact with person with aphasia. Use positive, supportive body language and reinforce whatever he says. Make sure that, okay, look, I could follow you. Did you say this? I know this. Please, so many times when we counsel and when we see a person, we say, I understand you have this problem. Ladies and gentlemen, no one understands anyone's problem. We only know that there is a problem. So the word understanding until and unless someone has suffered. Rate and clarity of speech. Use a rate of speech which is slow, clear, and his mother tongue. If he's talking in Tamil, he's talking in Kannada, use that. And use a speech which is clear, crystal clear, small phrases, and the language which he or she likes. Provide time to him. Several times a person requires little more time. Give him little extra time to express. They will require some time to formulate sentences, words, and execute. Observe from his body language and facial expression as well as intonation that, okay, he can understand. Is he not able to follow? What could be his feelings? Because most of the time we can understand that, look, he's able to follow, he's not able to follow, he's able to read. Make sure to label. Okay. Professional must use words what they have understood. Like when he says what food, or he would have said it, you always say that, okay, are you feeling good? Do you want food? Nowadays, there are so many these emojis which are there. You can use it. Okay, because that will say that, okay, how feeling are you? All of us say that, are you feeling good, bad, happy, excited? Confirm. This will give a little bit of more robustness in his feelings. Stick to one topic. Never ever change the topic. If you are talking about him, talk about him before shifting to any other things. Restart person aphasia's views and concerns. Make sure that we restate the feelings and concerns. Please understand, he's the same father, he's the same brother, he's the same grandfather. We need to restate that our concerns, our views are legitimate, and these are honest. Confirmations. Professionals should ensure that reactions to the feeling of person of aphasia are at optimum. Do not provide false feeling to person of aphasia by saying, I understand. Because one cannot understand how person with aphasia feels. It is better to provide a statement. I understand you are finding it hard to communicate. I'll try my best to improve your communication. I'll try my best to improve your vocation. I'll try my best to improve your walking, talking, physical, whatever we say. So do not give. Avoid certain type of questions. Avoid using yes or no questions. I always say it is advised to use more of open-ended questions rather than closed-ended, because that will give you a broader perspective what person feels. Reserve reassurances. One should try to understand person with aphasia's problem. One should reserve reassurance until they fully understand the person with aphasia's views, feelings, and concerns. Sometimes we reassure that no, all is well. You will go back to work. You will do this. I think we need to reserve. Best way is that we are trying our best to improve your communication, your physical, your mobility, your vocation. Let us try it. But never ever give a false hope to the family. Never ever give a false hope to persons with aphasias. Written. Sometimes people with aphasias can write, but not all. If they can write, please provide them. Use paper and pencil. That's the old scheme. We still we say use it. It can make a lot of difference in their life. Sometimes this is what we have been doing. It is setting up a meeting with another person with aphasias who has undergone therapies, who has improved it. This will boost the morale of the family as well as person with aphasias, and it will give a lot of self-esteem to them and a lot of confidence about you and your services also. We have been working in a group therapy. Now, we have been working in a group therapy. I have been looking into a group therapy, which I say by the, to the, for the person with aphasias. So person with aphasias working. So there can be one person with aphasia who will be performing little better. He leads the group. Because what I have understood, because what I have learned is that a person who is having a problem, he will be in a better way to understand, better way to communicate, better way to convey. And that way they build a lot of what we call as the concept of belongingness, attachment with each other, and they understand. So group therapy works. But sometimes we have to look into each individual, whether they are receptive to that. Some individuals don't like, but most of persons with aphasias love the concept of group therapies. For families, what we need to do is the family needs to be told about the problem which is realistic. What are its associated problems? Issues regarding return to work. We should be very careful. I have been working with this and I have been telling them that give me 3 months time. I will get back to you after 3 months. I don't want to commit that he will get back to work. Even if he gets back to work, because now there is a Rights of Person with Disabilities Act, and as per Rights of Person with Disabilities Act, aphasia is considered as a disability. So we should be able to use that tool so that they can go back to work. Because the Rights of Person with Disabilities Act clearly says that no one can be deprived, no one can be discriminated. And even if he has got 80% disability, it is the role of the organizations to make adjustment accommodation to the work. Plus, there is a possibility of change of the job. So, for example, someone was working more of the job involves communication, or the job involves certain high levels. He can move to a desk job. Let us say teacher is there. He can move to the librarians. There is a provision in that as per the act. So we need to understand the family dynamics. We need to understand the dynamics of the person. We need to understand the dynamics of the employment process. So while communicating with the family, provide a realistic picture. A family approach to person with aphasia is the best. Keep the communication approach open and have strategies which can be best to understand their views. While communicating involvement in family matters, we always say that when you involve these persons with aphasia, involve them in all family matters. Like you are taking decisions, minimize the distractions, importance of early intervention, offering information and resources, social networking, rights of person with aphasia. There are clear-cut rights of person with aphasia as per RPWD Act. If a person is having aphasia, he has got a right to avail services, he has got a right to avail disability certification, he has a right to retain the vocation. and it is the duty of the organizations to make the changes. Communication must address to the following aspects in terms of vocation, in terms of hobbies, in terms of learning. It is at a holistic level. So that means we are trying to say communication involves both coordination, connecting and communicating effectively for the person, by the person, for their family members. So it's a holistic. So it involves at occupation level. Person with aphasia caregiver should be realistic that they should be able to resume the work, or if they have to take a step down. Sometimes we say change in job. Marital issues. Shattered channels of communication leads to tension and hopelessness between person with aphasia and their spouse. Miscommunication often leads to marital dispute. There have been issues. We need to be very open. That's what I'm trying. As a professional, we are not working only with the condition. We are working with the person. And person has got every issues. We need to be more receptive about that. Finances. Intensive medical care and receiving therapeutic intervention regularly pose a great threat to financial. We need to tell them what are the financial. Like a person who is having a disability, they can get exemption in terms of income tax. There is income tax exemption by the family or the caregivers, whoever is paying tax. Hobbies and leisure, we should ensure that person carries out certain things. Like if he likes going out, let him go out, take him out. If he likes meeting friends, take him around, let him attend. If he likes listening to music, allow him to do it. Ultimate goal of communication should be providing support and respite to person with aphasia and their caregivers, promoting better social interaction and participation, improving quality of life of person aphasia and caregivers. Please understand, we are not working only with person with aphasia who has stroke. We have to work with the family, the caregivers. There is a lot of burnout in that. And that's what they say, the order of recovery. When they say most of the person with aphasias after stroke, what they say is, okay, life. So once he's able to survive, what people say is, can he little bit walk? That's what say over disabilities first, because it's visible. So they'll say, okay, can he walk? Then family will say, oh, I will be more than happy if he can talk. And then they will say, he can walk little, he can talk little. I wish he can go to the washroom. He can take baths. He can put his dresses. That's the independence. Then when we say, okay, he's able to walk, talk, he's little independent, then say, I wish he can go back. And this is the same order which you have to follow when we also read it, that, okay, now can he go to the vocation? Can he go back to work? Once he goes to the work, we look into psychosocial. That, okay, now what work he does, he is known, he is stable. And once he is able to carry out the work, that is what we call as the identity. Then we looked into personal, that, okay, now my work is known and it is acceptable. It's my personal, I'm independent. And then comes your identity that, look, now people know me by my name, by my work, but not by my disease, disorder, or the disabilities. So what we need to do is, we need to look for SWOT analysis, what I always say is strength, weakness, opportunities, and threats from the environment, from the family, from the society, from the nation, from the disease. Or we also need to look into how good is this political, social, economical, and technological era which supports these persons with aphasia. We also need to typically what we do is we look from life to physical communication as well as the emotional person. That's what I'm saying, that it is bigger. And to treat these things, we always say that we look for life participation approach. So it is a holistic person which looks from the long-term consequence beyond the acute description of communications. And we say it is basically a consumer-driven services. That's what we say. It's a philosophy. So they say, in spite of all the issues, how well the person can be integrated, how well the person can retain his identity, how well best the person can become a productive member. That is the life participation we called as 360-day improvements. So what we need to look, we need to emphasize on the availability of the services, what person has, enhancement of his life participation. All those who are affected with aphasia are eligible for services. Personal and environmental factor. Sources is measured by documented, that which services when we provided, what was the improvement, what was the impact on these individuals. So we say personal and environmental. It can be physical, psychological, emotional, social, attitudinal. Major what we look into is the attitudinal perspective. The group therapy I talked to you about this. Family members, communication and all, we need to keep channel very open with them. Service delivery, when we looked into, when we provided services, we can provide the services at 3 levels. Face-to-face, we can provide through telepractice as well as the hybrid base. And we have been very successful. Initially, I always say provide through the face-to-face services. And it has been possible that either you visit the patient's place or the patient visits to your place. So that is possible through the face-to-face. And then we can also use technologies, that is using our what we call synchronous and asynchronous technologies, using the tele mode of services which we can use. And let me tell you that once, but it is not in the initial stages. What we do, we use more of a hybrid-based approach. Initially provide few days of session face-to-face, then make sure that he can go to the technology, and then you can always introduce the technology and which he or she can help you. So this technology, what it does is it can reduce several barriers. Barriers in terms of geographical, physical, lack of service, high cost. And it is more safe and secure. Because sometimes, I know this is not right on my part, but sometimes a patient might fix you also. That this person behaved, abused me. Abuse can be physical abuse, sexual abuse. But when you use technology, everything is recorded. You are more safe, you are more secure. So there are activities which you can carry, and all the techniques which we use, definitely we can deliver. So we can deliver the technology for both assessment, intervention, consultation, as well as communication with the clinicians also. And we provide both synchronous and asynchronous. Synchronous is nothing but real time. Asynchronous is like your whatever you see Facebook, or you can use hybrid based. So asynchronous is nothing but sometimes like you can have various apps are which are. So these apps, like some apps like constant therapy app, where you can carry out the activities, and then a clinician will see how much he has done, what activity has not done, and what are his issues which can be resolved. This is what we call as the asynchronous. Thus I say recovery is not just from the condition, but it is connecting, communicating, coordinating, and commuting back to them. So person with aphasia, we have to look from a holistic point of view. So what we need to do is, as a professional, we need to build good networking, good relation with our colleagues, maintain them. We need to communicate and maintain them. We need to be very professional in our approach, what we convey to the family member, what we convey to our professionals. We need to nurture and retain and acknowledge who is doing well, and always also give a appreciation as well as a feedback that look, this worked better, this did not work. How best way we can integrate it. We also need to do a networking within and between the caregivers, the social, the professionals, as well as the stakeholders. But all those things, when we look into, are going to transfer. That's what we look into. We need to connect with the stakeholders. We need to connect with the family members, professionals, policy, and advocates. So what we need to connect, communicate, and coordinate with stakeholders, family members, professional policy members, and advocates, which can make a difference in the lives of persons with aphasia, the family members. So there's a last which I say, a nap can make a person happy for an hour. A marriage can make a person happy for a month. A lottery can make him happy for years. But for lifetime happiness, he has to find a way to make others happy. And that's what, as a professionals, we need to do. And we need to have a difference of attitude towards them and acknowledge them and try our best so that they can be made independent and productive members of the society. Thank you very much. If you have any queries, I'm open to suggestions, please.
Thank you, sir, for the wonderful presentation. So it's a time for questioning.
Good afternoon, ma'am.
Yeah,
I'm
you
Dr.
can go ahead
Purna
with the
Devi.
question. Yes.
So I just want to ask one question to the sir. Usually, we say it is be fast, but
Madam,
actually
be fast. Yeah, madam.
Actually, sir, B-fast is a symptom.
Yeah,
It is an
ma'am.
early symptom where it arises, but can't we identify that before that because it has already been any aneurysm or hemorrhage, but it is an early symptom.
Yes, ma'am.
But I have seen some of the patients with these symptoms itself, early going hospital also, they have end up with many danger situation. They had very severe paralysis and they had so much of things. Even we identified it earlier also. So can't we
How,
identify it little bit earlier? Any other symptoms are there that we can?
ma'am, see, this is what I have seen, and this is what little bit I know. Miss, one thing, I believe in God, right? So I always says God gives us chances. The problem is people don't pick up those leads. Anyone who had got a stroke, cardiac arrest, everyone has got a time. So the thing can be either there can be sometime numbness, blurring of vision, okay, or there can be people will say I am getting giddiness. Okay, what happens? We don't pay attention, and as a result, the person might have full blown stroke. But earlier it can be only through if you go for an annual health checkup. But
That's what.
people who yes, ma'am.
So some people they don't even deny. See, even some of the people who are normal, they say after taking some of the diagnosis, they give so much of problems, but still I don't have problems. So many myths they have actually.
Yeah, ma'am. In India, ma'am, I'm sorry to say, if you have read 2 days back or 3 days back, if you see, I think it was in Times of India. Okay, there is a place in Rajasthan. People who have got a full-blown stroke, they go to a temple. Okay, I forget, it is near Nagore. I forget the name. So they go there, and they say once go there, they improve it. So here also in Mysore also we have got some people here nearby place. So they go to those Swamijis. So I keep on telling them, why don't you come to Goswami also rather than going to Swamis and all. So what I'm trying to say, there are a lot of myth. Well-educated people are going. So the problem
You're right. You're right.
I'm telling in India, it is hard to educate the educated people. Very hard. And medical fraternity also will not tell that, look, you need to go, you need to avail services. They will say, till my bill is there, I'm all is well. After that, you take care of them. Full-blown stroke people, even a full-blown stroke people where the medical facilities are not available, they will also keep him for 1 or 2 days. Then they'll say you can go there. So, but identification of a stroke prior to full-blown, it is little risky. Yes, we know these are the risk factors. Like
Okay,
nowadays,
sir. Thank you. Thank you.
like nowadays, what I'm not getting as a traditional stroke patients. I'm getting another variant. Like you have this IVF. Okay, IVF is becoming a very common because this is because of the drugs, metabolic system, and as a result, it has thrown to the brain, and you get a stroke. And then a person, when you say he or she would have lost her speech, then she will ask, sir, shall I go for an IVF treatment? So when you say, please don't go, the doctors will say, no, nothing is going to happen. So what I'm trying to say is, our professional to commercial, as there is a lot of distinction and demarcations.
Okay, sir. I can understand, but I think recent advances still more has to be improved to identify.
Ma'am, identification, ma'am, even if you identify within first 1.5 hours, if they can go to a good hospital where there is a tissue TPA, they inject it, person walks out in 3 hours. But hemorrhagic is there, then it takes time. But early identification, full-blown till that is there, you will not do. Yes, you will get some time. You will get some time. It's not you, the person will get a some.
Okay, sir. Okay. Thank you. Thank you so much.
Any other questions? If there are no more questions, we'd like to conclude the webinar. I would like to take this opportunity to thank the speakers of the webinar today, Dr. Karthik Babu sir Principal, College of Physiotherapy. Sir, we thank you for taking your time from your busy schedule and imparting us a knowledge on stroke rehabilitation. Sincere and heartfelt thanks to Dr. Goswami, sir, Professor in Speech Language Pathology, Aish. Sir, I am proud to share that I'm your student, and it was nice listening to you after a long time and relearning a lot of new things. Thank you, sir. So thanks for your enlightening us on the incidence, prevalence, and giving us a realistic view on stroke and aphasia in Indian context, and as well as what are the practices in Western too. And thanks for sharing the knowledge on the quality of importance of focusing on quality of life and looking at the aphasic client as a whole. Thank you, sir. We thank our director, Dr. Nachiketa Rao, sir, for permitting and encouraging us to observe the stroke day and conduct various activities on the same. So sincere thanks to Dr. Santosh Khanna, sir, HOD, Therapeutics, for organizing the webinar on stroke rehabilitation, and also for encouraging us to conduct all the various activities this week we are carrying out. We thank Sri Bimte sir for supporting us and organizing the various activities on stroke rehabilitation program. Our sincere thanks to all the faculties of therapeutics, physiotherapy division, and speech hearing and communication for all their support rendered towards conducting the various activities on stroke rehab with respect to stroke day celebration. Thank you one and all. Thanks all the participants for your patient listening. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you.
Convey my regards to our sir.
Hearing your talk, sir. Thank you so much. Thanks for the opportunity, sir.
Thank you. Thank you.
Thank you, sir.